Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Dear everybody, most welcome everybody. It's our pleasure for South German Hospital Group to hold that webinar about our international current problem, COVID-19, and the hottest current topic, which is preparation and usage of convalescent plasma for treatment of patients or passive immunity of others. Currently, everybody is looking for that virus, how to give immunity, and everybody is doing and thinking how to give treatment. Some is in the preventive medicine and the infection control to prevent infection and to give immunity, and some in the treatment. But for convalescent plasma, it would play the double role. So it is the most important topic. So it's our pleasure to have international eminent speakers who will describe to us what are the safety precautions done in blood bank currently by Professor Dr. Salwa Hindawi, Professor in Hematology, Transfusion Medicine at King Abdulaziz University, Jeddah. And after that, the protocol for usage of convalescent plasma by Professor Dr. Hani El-Hashmi, Director of Oncology Center, Hematology and Stem Cell Transplanting Specialized Hospital. Then Dr. Majid Ikrabi will give us experience in Egypt about also the role of the convalescent plasma. So now our first topic will be by Professor Dr. Salwa. Dr. Salwa is a professor in hematology transfusion medicine, King Abdulaziz University, Jeddah. She had her MRCPS in hematology and certificate in transfusion medicine. She's a member of WHO Expert Committee for Biological Standardization and Blood Safety, and she is a member of APP, American Associated Blood Bank Committee for Global Standards, and a member in ASPT Global Safety Working Group. As well, she is the chief editor for Transfusion Special Edition from Middle East. She has many publications in American Association Blood Bank and as a cab inspector as well. She is always and mostly the president of many international conferences all over the world in hematology and transfusion medicine. Her topic will be about blood safety during COVID-19 outbreak. Prof. Dr. Salwa, please.
Thank you, Dr. Osama. Thank you. I would like to start with thanking all organizing committee for inviting me today and to speak in this conference. I would like to thank everybody attending with us, and especially I would like to thank Dr. Osama for arranging for this webinar. Bismillah ar-Rahman ar-Rahim. I'll just start with my slides. Okay, I need to minimize this. Just, okay. Today I'll talk generally on the blood safety during COVID-19 outbreak. I'd like to say that there's no conflict of interest, nothing to declare. Outline of my presentation will be on the introduction, challenge for blood centers, blood safety measures, and SARS-CoV-19 blood viremia, implication for blood safety, and then conclusion. As we all know that coronaviruses are a large family of viruses that causes illness, ranging from common cold to more severe disease. Coronaviruses are zoonotic, meaning that they are transmitted between animals and people. As we can see in this photo, it can be transmitted from animals and different animals, and can be from person to person also. Till today, coronaviruses, there are 7 human coronaviruses have been identified. And the 3 of them we know about that they can cause more severe disease. SARS coronavirus in 2003 and Middle East Respiratory Syndrome coronavirus, MERS coronavirus 2012, and novel coronaviruses, SARS-CoV-2, which is on 2019. They are all enveloped positive strand RNA viruses. This is how it looks like, the coronaviruses. Corona coming from crown, and because the virus looks like crown from outside, and they have the spike protein, they have envelope protein, nucleotide protein, and membrane glycoprotein, and the RNA material. On December 31st, 2019, WHO was informed of cases of pneumonia of unknown cause in Wuhan city in China. There was a discovery of the novel coronavirus, which identified as a cause of Chinese authorities on 7th January 2020, and was temporarily named 2019 new coronaviruses. What is COVID-19? COVID-19 is a new strain that has not been previously identified in humans. This virus first encountered in Wuhan city, in China in December 2019. It's likely originated in bats. As this virus is new, we are learning more all the time, and what we know now may change at any time. If we can see from this figure, it's in general just to show you that the infection started with asymptomatic stage, then it's coming the onset of symptoms, and that during the onset of symptoms, we can have the PCR positivity, maybe from days 5 to 7. Then the development of IgM antibodies, then IgG antibodies coming through. And this I'll talk later about it in a clear way in my presentation. In general, our statistic up to date, we have in Saudi Arabia 123,308 cases, total confirmed cases. And we had new cases today, 3,366. And we have a new mortality of 39. Although we have a mortality of 932 patients, but this mortality is only around 1% of the total infected cases. And we have a total recovery more than the total active cases. These graphs can show us that every day we had our cases, which is here ICU cases, which is nearly last week, it's near each other, around from 23 up to 45 cases per day. And we have this also, it's nearly the same through last week, every day between 30 to 40 nearly patients who are died. What's good about it, what's happening, that we have recovered cases. It is more than what we have active cases. And this is a good things or good monitoring. And this can just tell us that we have a good health care, and we had a good following from Ministry of Health on cases and on how to treat cases and follow up cases. Now, if we come to challenges for blood center during COVID-19, we can just see that we are looking for protection of blood donor during donation, protection of blood center personnel, and protection of transfusion recipients after transfusion. We had in many countries experienced reduced donation, and this is worldwide, internationally, because of fear of infection and frequent traffic in blood centers. Also, the personnel could be infected by asymptomatic SARS-CoV-2, and we don't know if there is donors who are asymptomatic or donors who are still in the window period and they didn't get the infection yet. And this worrying a little bit. And we had for transfusion that we don't know the recipient if they can catch, maybe they have the SARS-CoV-2, which is below detection level. If we talk about measures taken by blood centers to mitigate risk, protection of blood donors during donation, We have to look at fixed appointment to keep distance between donors. They have to use a mask and the distance between waiting chairs. These all can help, and if they get appointment, they will not be worried. We don't have to accept at the same time more than 2 donors. We have just to follow what should be followed for making sure that we are taking care of not to catch any infection by the donors from any staff and vice versa. For the staff, the same. We want to also let them wear all the time masks, gloves, disinfecting, and they have protective clothes. Donors must wear a mask and disinfect their hand before and after donation also. For blood transfusion center, testing is not visible now to do testing for all donors. And it is not sure, and we'll talk about it, that if it's transmitted by blood or we can find it. And to get rid of this, we may do, and it will be very good idea if you can do pathogen activation of platelets and plasma for all donation, although we didn't yet have the red blood cell inactivation, and this may make a little bit problem. And we hope that it's in its way. But pathogen activation for convalescent plasma will be a very good idea if the center have it and they can do. In general, blood safety aims to ensure that everyone has access to blood and blood products that are safe and available at reasonable cost, adequate to meet needs of patient, and transfused only when it is necessary. Who are the group who needed blood? Even during COVID-19, the patients still need blood transfusion. And we have a certain group, they need all the time to get blood transfusion, like cancers and leukemia patients, transfusion-dependent patients like thalassemia major, and during emergency and trauma, we need to have blood ready for these patients. And really, we have to take care of having enough donor and enough blood supply at our place. Donor concern usually, they usually ask, will I get COVID-19 at the blood center or not? And this is for sure, we have to convince donor, and we have to do all precautions necessary to make this not happening. Is it safe to donate blood during COVID-19? And why they asking these questions? Because they are thinking of the immunity. Some of the donors saying that it may decrease my immune system, and I will not be able to fight the coronavirus, and it's better not to donate. But this is not right. And we have to explain to the donors that donation, it will not affect the immunity and decrease it. It can be initiate or boost the donation, the immunity of the donors instead of. What's the measure usually taken by the blood bank? As you can see again, this is the distance it should be taking, and washing hand very well, and to have appointment usually for all donors has to come with appointment, and to wear mask all the time, and taking temperature before and after. It's better to take temperature for all donors, also for the staff, and they have to wear to frequent use of alcohol hand rub. Report any symptoms after donation. It's very important to report any symptoms from the donor after donation, because if they feel fever after they go out 1 day, 2 days, it's good to inform blood transfusion services that they can just contact and just follow, make traceability of what they donate, and just make sure that they are not giving it to any patients, and they follow the staff and just check what's going on with the staff. For staff, usually before starting work, and it's better to check their symptoms and temperature, because we don't want any staff who had catch coronaviruses to come to work and just join others and maybe transmit the infection. They have to wear the mask all the time, wear gloves when they do venipuncture. They have to use washing their hands or use the alcohol hand rubs. And donation process, standard blood precaution procedure should be taken, and all donors has to be going with the questionnaires and all activity physical examination of blood pressure, weight, and everything we are doing, they have to do it. Plus, they have to make sure of the questionnaires if they have any contact with any recent COVID-19, if they had COVID-19. All this has to be specifically asked to the patient and getting their temperature, to the donor, sorry, and getting the temperature before. Usually they change of bed sheets and disinfect the donor chairs after every donation to make sure that there is nothing going on and to make donors satisfied that everything is going well. This is a brochure which we have done and in Arabic and in English, and we just distributed to people just to make sure that donors understand what is going on and when they have to donate, and just also to make them know that important action is taken by blood donor area. And this can be of help when donor read it and the population society, they know about it. There is one more important thing we have to do, that we have to think about patient blood management, and we have to think that we don't have to transfuse patients if it's unnecessary. We know that patient blood management, it's an evidence-based approach to optimize care of patients who may need blood transfusion through improving patient own blood and avoid unnecessary transfusion. We try to do this through using alternative to transfusion and adherence strictly to the guidelines, and use evidence-based transfusion threshold and reduction of non-emergency cases, elective surgery if we need to do so. Something important from ABB, they just having this why give to when one can do or will do, that choosing wisely campaign for red blood cell transfusion. This was good start because really it's found that some of the patients, they need only 1 unit of blood, and you don't have to give much of blood if they don't need to have this, and they return back to 1 unit transfusion. Preoperative anemia management is very important and essential to treat anemia that you will not need for these patients if they are not anemic. They don't need to transfuse them, and they don't need to use transfusion unnecessarily. Using antifibrinolytic agent to reduce blood loss, intraoperative autologous transfusion, or in general autologous transfusion, and use anesthetic management, surgical methods to reduce bleeding and to reduce phlebotomy and blood loss. All these measures can help not to use a lot of blood and to manage blood very well, and to give only to the patients who are in need. Also using the hemovigilance system, or the system we are using for monitoring any adverse event occur to donor or patients. This is very important to continue during COVID-19. We have to follow the general precaution by national international body for prevention of COVID-19 infection, and we have to do good traceability if we had any information about suspicious case of COVID-19 from donors, and we should do a system for reporting any case of COVID-19 among donor, staff, or patient receiving blood products. And Ministry of Health, they have this HSN who we can just report all cases, or we can just inform, but we have to follow up and do traceability for all patients and donors. New important rules for blood service in COVID-19 pandemic. Now you have to do efforts in blood transfusion services in donation area with collection of convalescent plasma. We do have to recruit the donors who are recovered from COVID-19 to donate convalescent plasma. We need to convince them and reassure them that it will be okay and they will help other patients. And this is a new rule for our blood transfusion services everywhere in the kingdom. Experience in apheresis collection and donor management, better quality in processing and storage of the collected plasma. This need to be having experience by staff working in donation area collecting for the convalescent plasma, and centers has to just recruit the donors and train their staff how they can manage this. And also therapeutic apheresis. If we think about therapeutic apheresis also, we need again to take care of therapeutic apheresis. If we will going to use it for our patient, COVID-19, we need to train our staff. We need to make sure that we can do it in the right way. And all these things has to be done under the protocol of either Ministry of Health nationally or under research procedures. Also, we can do zero prevalence of COVID-19 infection in the population. And this is all nearly a new role to most of the blood transfusion centers in the kingdom. SARS-CoV-19 blood viremia implication for blood safety. There are many studies done to detect if there is any patients or donors have antibodies, and just to make a zero conversion, to look to the zero conversion of these patients or donors. There is a study showing that all SARS-CoV-2 patients in a test group of 60 developed anti-SARS-CoV-2 IgG within 6 to 7 weeks, 100% after onset of symptoms. In another group of 285 COVID-19 patients, IgG seroconversion reached 100%, detected 19 days post-onset of symptoms. If we can see in this study, they were just showing that the antibodies to SARS-CoV-1 was starting from day 7, the seroconversion, and it reached a peak from 3 to 6 months, the antibodies in the serum or the plasma of the patients, and it can be staying up to 6 years in their plasma. But for COVID-19 or SARS-2, it is not clear till now how long it will stay and when it's reached the peak. But they are imagining that on the day 7 it can, or maybe they have studying that it could be 60%, but nobody sure till now how much it will reach. Studies is still underway to discover when it's reached the peak and how long it will stay in the plasma of patients. This can show us the timing of antibody development after SARS-CoV-19 infection. And from this graph, which is done by Mayo Clinic laboratories, they show that first week the viremia starting, and viral RNA can be detected till 2nd to 3rd weeks, and it's coming drop from the 2nd weeks, and by 6 weeks it's not there. But antibodies, IgM starting from the 1st week with IgG, but increasing to the peak in the 3rd to 4th week. IgM is coming down again, but IgG still going on from the 3rd week and staying for a longer period, and not yet detecting how long it will stay. But IgM declined rapidly from 5 to 6 weeks post-onset, and IgG remains positive for more than 10 weeks post-onset till today. They know about this information. And this is good to know about for IgG antibodies, as what it will be the role for serology play in SARS-CoV-2. We can use it just to do epidemiology prevalence studies or to know contact tracing. We can use it also to identify of potential convalescent plasma donors. As in some studies or some experts, they just state that if you use antibody IgG and it is high, its peak high, it could be equivalent to antibody neutralization test, and you can get it as a guide for convalescent plasma donor. Support in diagnosis of COVID-19 in BCR negative patients late in the disease, when the BCR become decline and it could be negative, antibodies IgM and IgG will be still in the plasma of the patient. It can help also in evaluation of immune response to candidate vaccines, and it's not recommended to be used in acute recent COVID-19 infection. Low genomic viral load in plasma of symptomatic patients discovered in few studies, and the evidence of viremia in asymptomatic donors, risk of blood donation, also discovered in very few donors in certain study in China, and the rate of asymptomatic infection unknown yet. Transfusion transmitted not showing yet, considered theoretical risk till now for all respiratory viruses. It is considered a theoretical risk. There is no any case reported that there is transmitted by transfusion. And this paper have done in China by La Change and colleagues. And this is what they got as a conclusion for their study. What will be next for us? We know that since 1918, we had the Spanish flu, and then we had a lot of other viral infection, which becoming serious one and become endemic or pandemic, reaching by MERS-CoV virus and Zika viruses. Then now with SARS-CoV-2. What do we know about all this? What will be next? When it will be the next one? How and how fast it will be transmitted? How and how fast disease will progress? Nobody knows. And we have to be prepared for all this in the future, that to be prepared for any pandemic, what we can do. This figure can show that the number of living species from all organisms currently known, and shows that it's a lot of species there, and for viruses around 1,000 viruses at least. And this all shows that it is all the time we have evolved, we have something evolved, and we have to take care of this. In conclusions, measures to restore and gain public and donor confidence in blood donation are extremely important during COVID-19 pandemic. Early implementation of measures enable us to secure blood safety and supply, and support from staff, from donors, society, media, authority are essential to secure the blood supply. We have to learn from this pandemic to be ready with a clear, effective plan to secure blood safety and availability during this pandemic and any future pandemic. This is my references, and this is just to invite you all to be with us tomorrow for the World Blood Donor Day celebration. It will be from 5 to 7 p.m. tomorrow, our time, and you are all welcome to attend. This is the last slide. I will thank all of you and just show you what is we have to do all the time now, and for getting distance and taking care of the precautions. Thank you, everyone.
Thank you, Prof. Salwa, for that comprehensive presentation. As usual, very comprehensive and very expressing. And the most important is the issue of that donation will not reduce his immunity, any donor. And we need every donor to donate blood and donate plasma, convalescent plasma, and it's very important. Actually, we'll postpone all the questions for the end of our webinar. And now you will have the second talk for Professor Hani El-Hashmi. Prof. Hani El-Hashmi has his medical education in Manchester University in Canada, MC Master University in Canada, where he graduated in an MD degree 2003. He is also has his postgraduate training in internal medicine and University of Western Ontario and the hematology fellowship at that university. Dr. El-Hashmi is a director of Oncology Center at King Fahd Specialist Hospital in Dammam. He is heavily involved at all the national and regional level with the development of future strategies for this. His topic will be about COVID-19 and convalescent serum. Prof. Dr. El-Hashmi, most welcome.
Thank you very much, Prof. Osama, for the nice introduction. And thanks to the invitation. I'm really happy that I came after Dr. So she talked about a lot of the topic that's related to blood transfusion. So it seems like we're going very nice sequence. Thanks for the organization. I'm seeing, mashallah, tabarakallah, very good attendance. So hopefully we'll have a very fruitful question at the end of this session, inshallah. I promise that I'll actually be very direct and very to the point in terms of my slide that I'm going to show you. I selected the number of studies that has been published over the past 4 months about convalescent plasma and its use in COVID-19. And at the end, I'll share with you some of our local information as well. So before we start, this is a slide that I've used in the past 6 or 7 presentations that I've done over the past few months. We have to acknowledge Corona. Corona is a very tough teacher, and this teacher have taught us to look in the past, look at our history, everything that was done in the history, because history, knowing the history very well is going to save us in the future. It did teach us how we should learn new things and deal with the very unusual, and how we should change our current practices, our workflow, and we added a lot to our experiences. And on top of all of this, during this very unusual situation that the whole world is going through, we stay focused on what is important, which is family, patient family, and the community. So as what Dr. Sello has mentioned already, the coronavirus pandemic is spreading globally. Not a single country not affected by it, not a single country not affected by mortality. And there is a huge economic hardship for everybody that this virus passes by the country itself. So it is caused, as Dr. Sello was mentioning, by SARS-CoV-2, first identified in Wuhan in China. And it is one of the very attractive research questions in terms of actually from all the aspects of science, going from bench all the way to clinical trials. So this is a global look at what's happening today. We're reaching to 7 million cases confirmed, and we're reaching to almost 500,000 maybe by the end of next week in terms of confirmed death due to the COVID. This is our local dashboard in Saudi Arabia, and Dr. Sello have showed already those data. We have almost 932 deaths so far, and more than 123,000 confirmed cases. And the thing that is worrying a lot of us is actually the intensive care unit the past couple of weeks. And we're hoping that this is going to drift down and we'll end with our first peak hopefully soon. So the world realized that we're facing a new virus, that we haven't seen something on the same magnitude since the Spanish flu 100 years ago. Most of our standard safety precautions and infection control measures which we were very happy with 6 months ago, it seemed like it's probably need to be updated, and there were actually a lot of room for improvement, and hopefully we'll actually benefit from this pandemic in the future. And definitely we need to protect our patient and our healthcare worker. If we talk about treatment per se, there is a lot of treatment strategy that has been proposed for those following, let's say, our local protocols. So there has been a lot of update recently because of the new data that's coming up on a daily basis nowadays with regard to antiviral, antibacterial, and anti-inflammatory drugs. And there's a lot of conflicting data as well. As you all seen, some paper has been pulled back and retracted because of the data accuracy. So we all need actually something new for this virus, whether it's going to be vaccine in the long run, something we can help our critically ill patient in the hospital and in the ICU. So this is the subject of discussion, convalescent plasma. Very simple way of looking at it. A donor recovered from COVID-19 virus typically will have some sort of antibody in his system. We collect the blood through an apheresis machine and isolate the convalescent plasma out of it. We're assuming that there is actually antibody in that plasma. This antibody can actually help a patient in the hospital who is admitted either to the intensive care unit or high dependency unit, and hoping that this antibody will help this patient to recover his infection. So there's a number of caveats to this simplified approach that I'll talk more about when we talk about the studies that has been proposed so far. So potential mechanism of action, there was actually a very nice review written 2 weeks ago, published 2 weeks ago, and it goes through all the potential mechanism of action. Most of us are actually very interested in the very first one, in the immune mechanism, which is neutralization and suppression of the viremia. But there are some factors that might be a reason why we choose a plasma for, such as modification of the inflammatory responses, antibody-dependent cellular cytotoxicity, and also non-neutralizing antibody, in addition to the non-immune mechanism, which is the restoration of the coagulation factor. So all of those are actually potential and theoretically driven under testing in clinical trial. So this is what I just described is actually the plasma, a process of collection of the plasma, who was described nicely by Dr. Silva. So this plasma, if you transfuse it to a symptomatic patient, you're hoping for an improvement in the clinical status. So this is not a new technique. So this has been used in the past. Probably the very first documentation was back in the Spanish flu, back in 1918. Recently, we've used it in SARS pandemic in 2003. We used it in H1N1 pandemic in 2009, and also in the epidemic, the outbreak in Africa of Ebola in 2015. So there are some data to support this in different viruses. However, in COVID-19, this is still a question under studies. So several small studies have been published over the past 4 months. Since January, actually 6 months now. So since January, there is a lot of small series studies that have looked at the convalescent plasma and its efficacy in terms of improvement of the clinical status of the patients. Probably the first one was actually published in JAMA. As you can see, it was only 5 patients. This was in Wuhan. Those 5 patients received 2 infusion of plasma, convalescent plasma from recovered donors. So 5 recovered donors provided the plasma. Out of those 5, there was a clear improvement in the biomarker, inflammatory biomarker, AA gradient improvement, oxygenation, in terms of oxygenation. Also, there was some improvement in the imaging studies, in CT and X-rays. The second one was another case series of 10 patients who received single infusion of convalescent plasma and reported no adverse event. Some improvement in that report as well. 2 additional small ones, one actually reported 5 cases, the other one reported 6 cases, and all of them actually gave the similar kind of outcomes. However, if you look at the methodology, it was actually case series and confounders, and actually a lot of critique were actually given to those outcomes because it's a small number and actually a case series kind of approach to the study, to the publication. Many others have actually showed similar small numbers series, and all of them have actually gave this potential benefit of the plasma, but nobody has looked at it in more methodologically rigorous kind of approach. So when we talk about clinical decision making for patients who sits in the actually for whatever whether it's a COVID patient or anybody who's sitting in the hospital, if you want to take a decision on behalf of patients, you really have to have some research background to support the decision that you're going to take. And on top of that, you really have to have some clinical expertise, and patient preferences should actually play a factor in available resources. If you put in the middle, instead of decision for COVID-19, we actually lack all those 4 corners. So we don't have enough clinical research for this virus. We lack the expertise in this virus treatment, and patients are actually, unfortunately, when they come sick, the preferences to them for decision making is not very clear. And the resources available in one place is definitely different from the one that's actually sitting next door. So it's a very difficult balance to take, and it requires a lot of focus on what's needed to be done. So I reviewed the last 2-month publication, and I'll show you actually 3 studies that attracted my attention. The first one is actually in Mount Sinai. So this was actually during New York City pandemic. So this is the curve of the peak New York. So what they looked at 39 patients, and that was between March 24th and April 8th. And they did a match control. So this is a little bit better than case series. So you're trying to match your patient who received the plasma with the cohort that did not actually receive the plasma and see if there is a difference. So as you can see from the survival probability, the curve, the Kaplan-Meier that I'm showing, there is actually a significant benefit in terms of actually getting the plasma. And if you look specifically at mortality, so the outcome of this study was actually many outcomes. One of them was actually mortality. So if you look at the mortality, the plasma recipient, 12% compared to the match control, you had almost quarter, 1 in 4 of those patients died from the disease. So their conclusion was the convalescent plasma recipient were more likely to remain the same or have improvement in their oxygenation on day 14 with a significant p-value. And the plasma recipient have shown, as I'm showing you here the graph, some improvement in terms of actually survival outcome. And there was a signal toward better outcome if the patient is not yet intubated. So if the patient still requiring oxygen in high dependency unit on non-mechanical ventilation, they actually fared better than those who actually were intubated and mechanically ventilated. So this is, again, this is actually a recent publication in JAMA from the Chinese group from Wuhan. Interestingly, so the question they were looking at is actually the effect of the convalescent plasma when it's added to treatment compared with the standard treatment alone. So this was a randomized clinical trial, very well done as far as study protocol goes. The question was actually, did they have enough sample size? So the plan was actually to get 100 in each side, in each treatment group. So the treatment group, 100 patients, and also in the control group was 100 assignment, but they were not able to recruit enough patients. So they failed to recruit and they stopped, they terminated the study early, and they published the result at that point in time. Despite all of this, so they're not showing a mortality benefit at day 28, but numerically there is actually some sort of an improvement. However, because they actually failed to get actual required as per the study design, which was powered for that outcome, they could not actually get a fair conclusion. And they suggested that maybe it was underpowered and maybe there is actually an improvement. They couldn't find it on the study. And they said that there is no difference in terms of the analysis based on what they were the available data at that time. So the third study, this is the last one that I'm showing as far as what's happening in the research arena. So this is from Methodist. This is actually a Houston Methodist, Texas. Again, cohort of 25 patients received one single dose of convalescent plasma, 300 ml of plasma, convalescent plasma, and they were looking at safety, and they concluded that it's fairly safe, as what Dr. Sello is mentioning. Blood product, if you deal with it in a safe manner, inactivate the pathogen in the plasma, you're looking at just a blood product infusion. What was more interesting was actually a Cochrane review that was published 2 weeks ago. And what they did, they looked at all the study, that looked at actually the completed study and the ongoing study, and looked at their outcomes. So they included in this analysis 8 study that was published. It had 32 patients, and also identified 48 ongoing trial that was registered on the clinicaltrial.gov. So they reviewed all their inclusion criteria, exclusion criteria, and if there is outcome has been reported, they looked at it. There was a major bias in terms of the study that they looked at it in terms of poor reporting and actually a different severity that was included. Comorbidity of the patients were all over the map. And also treatment that was concurrent with this, with the plasma was all over the map as well. One of the studies that they mentioned in this was actually our local study in Saudi Arabia, National Collaborative Multi-Center Phase 2 trial, looking at the efficacy of convalescent plasma to treat severe COVID-19 and at high risk of developing severe COVID-19. The trial design was a non-randomized parallel assessment. So there is a match group and there is actually an intervention group. This study is actually undergoing an assessment now for expansion phase from the 40 to a different number. I'll give you the sample size later on in the slide. and it's actually hosted in Saudi Arabia and supported by Ministry of Health and many other collaborators. So we have more than 17 sites involved in this, and more than 100 expert scientists involved in this trial. So their conclusion, based on this Cochrane review, they were uncertain actually whether the plasma is beneficial or not, based on the available data, based on the poor quality data that was reported so far, to make a recommendation. However, they're waiting for the result of the 48 trial, and they will update this report once the outcome is available. So this is the national trial in Saudi Arabia. So this is actually the official website and also Twitter for it. Patients have registered on this. Physicians who are interested in participating have registered onto this website. The website received more than 1,000 requests for participation from patients and physicians. So the study currently is recruiting. Sample size based on 80% power with 5% level of significance, based on the most available and the most available data, I mean, actually out of the studies that's been published, survival benefit of around 12%, sample size calculated, whether we're going to use 1-to-1 ratio, one patient, one matched control, 352 with a sample in each group of 176. Or 1 in 2 or 1 in 4. The study group, the study committee group actually decided to go with a 1 in 4 ratio. So total of 575 in total, with 115 in the plasma recipient group and 460 in the match control group. So probably this is going to be one of the largest study that's going to be done on plasma, convalescent plasma and COVID at a global level. So as I said, more than 17 sites have is already active right now, and more are joining almost regularly. We receive actually requests to be added as a trial site. We recruited more than 200. We screened more than 1,000, but because of the antibody negativity in many of the patients that the donor that we screened, we only took 200, more than 200 so far. We actually treated with plasma more than 70 patients now, maybe even actually close to 100 now. Those are actually some of the participating sites so far. So I'll just take this as an opportunity to thank Ministry of Health for supporting this trial, all the participants in this trial, the study group from King Fahd Specialist Hospital, King Fahd Medical City, King Saud University, Qatif Hospital, Kmark, and National Guard for their support, tremendous support actually, as well as King Faisal Specialist Hospital, John Hopkins Aramco. I'm just trying to say them all in once, but many people have actually contributed to the study. In Jeddah, we have IMC, International Medical Center, and King Abdullah Medical Complex in Jeddah, Medina Munawwara and Asir, and a number of hospitals in Riyadh as well. So in general, so COVID-19, people look at it in a dark point. I think it's a very nice opportunity to improve patients' care and provider safety now and in the future. Just talking about this current experience, our local scientists in Saudi Arabia, we were able to identify a lot of area for improvement in terms of care provided, especially when we talk about safety of blood and blood products. So Corona on the bright side. So I personally learned so many things over the past 6 months. I know that we have in this country, in Saudi Arabia, world-class scientists. I've had the pleasure of meeting scientists in Jeddah, Prof. Azhar and Prof. Anwar Hashim, and most of my group in Jeddah, in National Guard as well, in National Guard, right? My colleagues, Dr. Naif Al-Harbi in Kmark, my dear and near colleague, Dr. Ahmed Al-Askar, Ahmed Al-Saghir, and many others who are actually contributing to this King Fahd Medical City, Dr. Zaidi, Nawar Al-Shihri, Dr. Jawahir in King Faisal, Dr. Hazza. A lot of names that I actually had the privilege of working with over the past 6 months. We have local expertise in this country that actually is beyond what you would imagine. Infrastructure opportunity that's available currently. in the country is huge that support research. Research support is actually up and running now, and we have a lot of people interested in doing so. And the last thing is community willingness. So I have learned so much about this in the past 6 months. In the past, we used to say maybe the community is not interested in clinical research. This specific trial taught us a lot. So a lot of people are interested to participate. There was a lot of concern whether patient and donor will be willing to come and provide. And that was never an issue. Keeping in mind, we had a period of curfew, lockdown, difficulty in moving between hospitals and actually doing any businesses in Ramadan and Eid. Despite all of this, we're getting tens of donors on a daily basis. I'm getting to my last slide, and I'm hoping that you can see with me, this is a beach, very nice beach, and you can see the waves for those who enjoyed being on the coast, like people in Jeddah, hometown, and also here in Dammam. It's very nice to see the wave, but remember, the second wave is always larger, and that's what have been published many times in the past. This is actually just an example of the Spanish flu. The second wave is always larger, so be careful and stay safe and save life. And thank you very much. Thank you very much for this.
Thank you too much, Prof. Dr. Hani Hashmi, for that presentation. And actually, it's very promising, the results that will be coming after this study. It will be very promising and very important, not for us only, but all over the world. And you already mentioned, or your colleagues and your healthcare providers, all the eminent professors that I know all of these 25 years, and all the important centers and very important studies will be done. So we are waiting for your results, inshallah, and it will be very promising, helping for the treatment of many cases in the future. Now you will have the third topic, and it's by Dr. Magdi El-Ikiabi. It's not connected yet. Okay, anyhow, until Dr. Magdi El-Ikiabi will make the contact and be valid, the presentation.
Dr. Majdi معانا دكتور.
Where is the presentation? Is present? Is it okay?
I will need to upload the presentation from your side because
yes, I will make it, inshallah.
Okay.
You will do, Mr. Allah?
Yeah.
Okay. So now you will have Professor Dr. Magdi El-Ikiabi. He has experience more than 35 years. He's a member of Egypt's National Board of Blood Transfusion, Ministry of Health, population since 1986, and is serving as a member of executive team responsible for Arab Transfusion Medicine Forum. Is a member of organizing committee of ISPT Working Party Transfusion Transmitted Diseases, and has chaired scientific committees of many of ISPT conferences. Also, he's a board of the member from the board of directors, member of World Federation of Hemophilia since 2010. He's a member of Blood and vice president of Egyptian Society of Hemophilia. Currently and always, he was also the main and head of the Blood Transfusion Hemophilia Center in Shabrawishi Hospital, a famous important hospital in Egypt. His topic will be about the role of anti-SARS-2, COVID-2 hyperimmunoglobulin. As mentioned in the lecture of Dr. Salwa, how many cases was improved, and also in the lecture of Dr. Hashmi, the people are improved by this immunoglobulin. So now please, Prof. Dr. Magdi, most welcome.
Thank you very much, Dr. Osama, for this kind introduction. It's a great pleasure and privilege for me to join this elegant webinar and share with distinguished speakers like Dr. Salwa and Dr. Hani. So I think during the first two presentations, there was enough elaboration on what is the convalescent plasma from COVID-19 convalescent donors, and also its role and its clinical application. So next, please. Since we started in Egypt to hear about the pandemic of COVID-19, we thought that we have to start a sort of intervention or research among many researchers. I think up till now there is like about 50 clinical trials registered from Egypt on the clinicaltrial.gov. And the aim of our thinking at this time was, according to the early publications, that the convalescent COVID-19 plasma may play a role in improving the outcome of the management of the patients, or at least decreasing the deterioration due to the disease. Next, please. Next, please. Yeah. So, I mean, at this time, the strategies to manage COVID-19 were to slow down the infection spread and to manage patients. And then eventually the thinking was to have the herd immunity to stop the pandemic, which might be through community infection, passive immunization, if we can successfully develop anti-SARS-CoV-2 convalescent plasma or immunoglobulins, and then the weighted mass vaccination when a successful vaccine is developed. Next, please. And in April 2020, the FDA issued its statement about prioritization of, next please, that prioritization of the use of convalescent plasma in the management of patients on an basis of clinical research. They have opened it wide, and they give high-speed licensing even to clinicians at their offices to use this plasma to treat patients on the purpose that they will register the results of their small experiences and manage to have a large database on the experiences coming from the transfusion of convalescent plasma to patients. Next, please. So in Egypt, we thought I discussed from our blood center with the Asyut University Hospital collaboration in order to prepare for a randomized prospective clinical trial to test the efficacy of anti-SARS-CoV-2 hyperimmunoglobulins, which we will prepare from COVID-19 convalescent plasma using a technology from a Swiss company that's able to prepare IVIG from small pools of plasma through medical devices, and to use this to test the efficacy, if this can be used for passive immunization for persons at risk of contracting the infections, like our colleagues working in with the patients with COVID-19 in the hospitals, whether doctors, nurses, others, and also to use it as a treatment for early cases of COVID-19. And this is a small difference from the current studies. We would like to focus on the early cases and also to do like a sort of preventive approach to prevent the risk of infection to those who are at high risk of exposure. Next, please. So we applied the protocol to the IRB of Asyut University and to the Ethics Research Committee of Ministry of Health, and we got the approvals in 19 April 2020 to start this study. So since about a month and so. And the aim of the study, as I said, it's determination of efficacy of anti-SARS-CoV-2 hyperimmunoglobulin in passive immunization to prevent the infection and to treat early cases of COVID-19. Next, please. And the design of the study is a prospective. Next, please. Is a prospective randomized clinical trial for efficacy of both arms, the passive immunization and for the early treatment of or treatment of early cases of COVID-19. Next, please. Yeah. So we aim to start subject recruitment and obtain their informed consent. And we will have like 3 groups, COVID-19 convalescent plasma donors, where they will consent to use their donated plasma in the clinical trial. The passive immunization group, who will receive the hyperimmunoglobulin for prophylaxis from the disease, and the COVID-19 treatment group, if they will accept to use the hyperimmunoglobulin in addition to standard protocol in their treatment. Next, please. We are now in the stage of collection of COVID-19 convalescent plasma. Probably this week, we will start the preparation of anti-SARS-CoV-2 hyperimmunoglobulin by these medical devices. And we aim to recruit 20 cases for passive immunization, 30 cases as early treatment group, and an equivalent number for both groups as a control group. Next, please. So regarding the collection of COVID-19, the aim is that we would like for this study to collect about 100 liters of convalescent plasma by plasmapheresis. We hope that we will be able to recruit 40 to 50 COVID-19 male or nulliparous female convalescent from between 60 to 100 to 800, 600 to 800 ml from each donor. And we hope that each donor will donate once weekly for 4 times during 1 month, so that we can collect the targeted amount of plasma that we need for this study. Next, please. Regarding the preparation of the anti-SARS-CoV-2 hyperimmunoglobulin, a little background about this technology. It is a sort of a medical device that consists of disposable dry blood bags, the use of caprylic acid, and where we pull about 4 liters of plasma from 20 different donors to ensure the diversity of the range of the immunoglobulins, particularly the neutralizing immunoglobulins or the neutralizing antibodies. And we subject them to 5% caprylic acid, which will precipitate all the proteins except the immunoglobulins. And in the meantime, this is a viral inactivation step for lipid-inverted viruses, which was validated by Texel in France, and proved to be very efficient in more than 7 log reduction of HIV and models for hepatitis B and hepatitis C. Then this will be followed in the middle. If you see this, the middle picture, this is like a cascade of bags that will be connected to ultrafiltration filter, which enables us to concentrate the supernatant 5 to 10 times to the level of concentration that we need. And then at the most right side of the screen, this is a filtration system that purifies the final concentrated immunoglobulin solution, and then followed by bacterial filtration. And then we have a bulk. Usually 1 batch will produce between 20 to 22 grams of immunoglobulins, and this can be distributed into about 8 small bags. Next, please. So, I mean, the inclusion criteria for the passive immunization group, we opt to choose 20 high-risk exposed persons, mainly healthcare providers, who are SARS-CoV-2 PCR negative and seronegative for the SARS-CoV-2 IgG and IgM. And they will receive a prophylactic anti-SARS-CoV-2 hyperimmunoglobulin selected population, can be both male and female, with age range between 21 to 50, and to have a matching group of 20 persons who will not receive the passive immunization. The exclusion criteria includes age less than 21 or above 50, nasopharyngeal swab SARS-CoV-2 positive PCR, presence of anti-SARS-CoV-2, and presence of comorbidities such hypertension, diabetes, chronic renal disease, previous thrombotic events, or states of allergy such as urticaria or bronchial asthma. We will obtain from them informed consent, and we will infuse between 2.5 and 5 grams of anti-SARS-CoV-2, and this was based on the outcome from the clinical trials for the plasma, where they were infusing like 1 to 2 units of plasma, which is equivalent between 200 and 400 ml. And this is the equivalence of immunoglobulins present in the 2 units of plasma, between 2.5 to 5 grams of immunoglobulins. The 20 controls will be followed for the same period without receiving the prophylaxis. We will observe for the presence of anti-SARS-CoV-2 antibodies in passive immunization group every week, and development of clinical COVID-2 or development of nasopharyngeal swab PCR at the end of the observation period. Endpoints: SARS-CoV-2 PCR negative at the end of the observation period, or development of PCR positive swab during the observation. This will end the study for this person. Regarding the second trial, which is for the treatment of early disease, it will include 30 patients that will receive the hyperimmunoglobulin in addition to the standard protocol of treatment, and 30 others who will only go with the standard protocol. The exclusion criteria is age less than 20, SARS-CoV-2 PCR negative, and COVID-19 comorbidities mentioned also in the passive immunization group. They are the same group. We also opt to contain informed consent. We will infuse a primary dose of 2.5 to 5 grams based on the body weight. If the first dose does not give a remarkable improvement or comparative improvement, we may opt to give a second dose according to the clinical evaluation. And we will include 30 subjects who are on the standard protocol without infusing the hyperimmunoglobulin as a control. The endpoints for us, if there is improvement or recovery, prevention of lower respiratory disease as we start with the early cases, and if the disease progresses and death, this will end also for this subject. For the infusion of the hyperimmunoglobulin, pre-infusion, we will record the clinical parameters before infusion, including, for the passive immunization and treatment group, the basal vital signs, pulse, blood pressure and temperature, blood count, liver and kidney functions. And for the treatment groups, will also include D-dimer, CRP, ferritin, and chest X-ray for follow-up. Regarding the infusion, the amount or the dose will be prepared we will advise for oral or intravenous hydration before, during, and after infusion of anti-SARS-CoV-2 hyperimmunoglobulins for 24 hours to reduce hyperviscosity and possibility of thrombotic event. Although the dose is very small, it's not like the, for instance, for the treatment of primary immune deficiency where we inject huge doses of immunoglobulins. The infusion is aimed to be like 14 ml per hour, and we expect that the infusion time, according to the dose, may range from 4 to 7 hours. Expected complications from the infusion is as reported, and as we have tried this type of preparation in 2 previous clinical trials with primary immune deficiency patients and with the pediatric population with the recent diagnosis of ITP, was typically some mild fever, chills, hypotension, or headache. And the post-infusion follow-up will be measure of basal vital signs as we did before, and also follow on the CBC liver and kidney functions. So far, regarding the project when we received the devices for preparation of immunoglobulin, we prepared like 4 batches or 8 batches actually now of mini-pool IVIG from normal plasma donations to validate the devices are working well. So far, we have recruited 10 apheresis donors from the convalescent plasma donors, COVID-19 plasma donors. We have so far collected about 8 liters of COVID-19 convalescent plasma, and we are setting up for a titration assays of anti-SARS-CoV-2 IgM and total by chemiluminescence and ELISA for total antibody titration in hyperimmunoglobulin preparation. We also are archiving samples for neutralizing antibody assay, and we are collaborating with the National Research Center. They have a biosafety lab, I think, level 2, and they are performing the neutralization assays. So once we prepare these hyperimmunoglobulins, we will send samples for estimating the neutralization assay. These are some data from the normal plasma that was processed by these medical devices. And the most important is that we were able to reduce the starting volume of the plasma from around 5 liters to only about 300 to 400 liters, and that we could concentrate the immunoglobulins from the plasma up to 5 to 6 times, which is very good that when you pull different types of donors, you more have the likely that you have a good amount of the neutralizing antibodies in your preparations, and then as they are concentrated, the infusion volume will be smaller, and also they are virally inactivated. Next, please. We compared also the normal immunoglobulin preparations that we did when we received the immunoglobulins to standard preparations, and we could see that we could achieve about 85% purity of immunoglobulins in comparison to standard IgG preparations, that the content of the immunoglobulin is about 75%. Most of it, about 85% is monomers, immunoglobulins, and less than 3% like dimers or polymers, and that, but it has some more content of albumin, which is not hazardous to the patients by any means. Next, please. So now we are recruiting passive immunization study population by obtaining their informed consent to start hyperimmunoglobulin infusion end of June. The subjects will be followed up for 4 weeks to determine the titer of anti-SARS-CoV-2 neutralizing antibodies pharmacokinetics. It's very important that when we infuse these study group for passive immunization is to know for how long the neutralizing antibodies will remain in their blood, and consequently is offering a kind of protection when they receive this. And this is, if this is really successful, it will It will be very helpful, at least for our medical staff who are every day exposed to during the care of patients with COVID-19. And we all know that the incidence of infection among the medical community is very high, actually. So we hope that if we have a sort of good results on this, that this can be something to help until the vaccination is on. We are, for the treatment, we will do the randomization sequential 1-to-1, and we expect the first infusion on early July. Challenges is ability to recruit and maintain target plasma donors. Now there is huge competition to recruit the donors from patients in need. And we do not know for how long, as Dr. Salwa said, will the convalescent donors will maintain enough titer of neutralizing antibodies. So these things we will see in the future, and hope we can, it gives us more information on how effective can be this approach. So my final slide is that we expect to have first interim report on this study by mid-August, and we hope to have the full result by September, October. With this, I end. Thank you very much.
Thank you very much, Prof. Dr. Ekiabi, for that very rich knowledge, very clinical, more clinical data and more live data about cases and about the collection and the usage and the results. But still the results, of course, as you mentioned, will be by August, and after that in September, October. Of course, very valuable. Thank you very much. Now for the questions, actually, we filtrate some questions and we find some questions are repeated. So I will just say some about it, and then we will try to say another question which is not repeated. Actually, my first question for Prof. Dr. Salwa, is there a standard international level for immunoglobulin against COVID-19 in plasma to allow this for treatment or for passive immunization? Is there a special level when there is, I have already this convalescent patient and I can take his plasma? Is there a special level I make antibody titer before it to judge he will be valuable or not?
Okay, I will just answer what I know from the international group and what I have. There is no specific level that we can just make sure that it will be good for the patients to be transfused, but it should be a good level of antibodies. It's better to transfuse at least more than 160 or 360 for patients with to get a benefit from it. Till now, no consensus on what is the level of antibody to give to patients and it will be okay and good for these patients. But it's better to do it just to know and to give something which is according to what happened and what studies before in other corona, that it's a good level to be give to the patients. And maybe Dr. Hani can also say something about it because they are working on this.
I agree totally with you. Currently, all the clinical trial did not actually specify a level of antibody titer. Some of the trial actually just infuse it without knowing the level. But efficacy of, hopefully, once the results are out, we'll be able to tell at what level antibody titers effect and outcome actually is clear. And that's, I'm hoping that will be not too far from the current.
Okay, please, the second question, which is more repeated, also, I like to direct to Dr. Magdi because it can be more known to him. There is many donations there. About the time schedule of for every patient. He gets the disease, then he is doing, he is positive, then he is cured. He will make 2 times to be negative, and either it will be like fresh frozen plasma, or it will be special another way. And if it can be pharmaceutically done as ready-made after that. The sequence of this is a question of many people want to donate, and what's the future of this plasma after the time.
Yeah, I mean, I mean, first, I was by coincidence for the first question discussing this with one of the expert panel of the WHO about the standardization of the titer of immunoglobulins, which can be efficient in treating the disease. And actually, there is no consensus, because as far as we do not have for any preparation a standardized reference from the WHO, we are not able to determine what will be the titer of the immunoglobulins that we want to have in our plasma or in our preparation for neutralization. There were like 2 papers from the Chinese people discussing the neutralizing antibodies, and they said that probably, especially neutralization antibodies, not the total immunoglobulins, I mean not the total antibodies to COVID-2, no, the neutralizing antibody, it should be above 80 to 160 titer. And they found in the second, more recent paper that Dr. Hani referred to about the aborted clinical trial, they found that usually the neutralizing antibodies represented like 25% of the antibodies, total antibodies against COVID-19. So it is still that we would like to see this. Probably in our trial, we will try to standardize the neutralization antibody titer, and then follow it in the recipients of the passive immunization to determine the pharmacokinetics for how long it will remain, what is the threshold that we anticipate to have it as a protective. Yani, for instance, for anti-hepatitis B antibodies, they opt to have like 500 international units per liter in the blood of the recipient for protection. So, I mean, a lot of work on us around standardization of this needs to be done, and it should include many participants in this. This is for the first. Second, now we see a gush of donors because the Ministry of Health in Egypt allowed for use of convalescent plasma for treatment of advanced disease, not the very late stages of the disease, but those who have low oxygen saturation are not intubated yet or not on now. So we see a gush, and we are following this with testing. We set a criteria for our study. We said that we would like to have 2 PCR negatives and to have at least 28 days post-discharge. And the reason for this is 2 things. One, to give the chance for the development of IgG to a good level, because when we saw some at the 15-day discharge, some of them was still having a low level of IgG. Second, because these donors, if they are, especially if they were ill, they may have this cytokine storm in their plasma, and in order to ensure that they do not have remains of this, we never know about this, that we give enough time for the donor to fully recover from the disease.
Yes.
And so we said 28 days should be this. I followed some now for 3 months. They still have the same titer of antibodies. It did not change. And as Dr. Salwa said, it can be for years or could be for less or more. We are still new to this, and we don't know actually what's going to happen. So it's very important that we will collect this, and we are trying, when we have this informed consent from our donors, to ask them even to continue to come even for testing, to test the level of their antibodies against SARS-CoV-2 to give us an edge how long does it stay. We see different patterns of immune response, but I mean, those who had like a sort of mild disease tend to have less globulin strength in their plasma compared to those who had stronger disease. We don't know. These are still, we tested like 100 donors, and these are some of the remarks that we are recording, but of course this is still very preliminary. So in total, we set the criteria as follows: 2 PCR negative, 28 days, male donor or nulliparous female donor.
Thanks a lot. Thank you very much, Prof. Dr. Ikiabi. Now, before the other questions, I have a question also repeated. Sorry, Dr. Salwa, for Dr. Hani, it's repeated too much. About the home isolation cases. Many of the people are having home isolation, and they like to know when it's a critical time and they have to try to contact a hospital, or it's not safe to be at home. If they make home isolation, they are positive, no hard or no difficult symptoms, but they are positive, so they are home isolated. Clinically wise, what are the symptoms or signs which make them be alert and they must move to be in hospital? Clinically wise, you have broad spectrum doctors in many hospitals, so what could be?
Allah يديك العافية. And I just have a small comment on the previous questions, مع Dr. Majdi. We probably are following the same AABB regulations of when to donate blood and plasma. I'm not sure if this is the same in Egypt or not, but we're repeated negative PCR is not required in Saudi Arabia anymore for actually recovery. So that is an issue with the donor for our site. So are you going to stick with that or not? This is a question actually I would like to ask. In our case, we were able to actually collect our first batch, so 1,000 patients screened. We were able to get negative PCR for all of them, because that was actually at the time the MOH and Wiqaya, our local guidelines. And since it's changed, so no need for PCR for actually confirming recovery now. Are you going to actually take this into consideration or not in Egypt? Because we are thinking about changing our donor criteria selection. For the question about when to go to the hospital, so any patient who have confirmed positive swab, they receive a notification from the Ministry of Health about the clinical status. They get asked to quarantine. Majority of them actually quarantined either in hospital or semi-hospital setting, such as hotels or things like this. So they have to be quarantined somewhere until they have I'm not sure if the wristband is available, but until that is available, nobody will be quarantined positive at home because of the risk of actually transmitting this to family members. The question that we get a lot is actually very general question. So I have people calling, and our patient population, they call in and say, well, I have a little bit of fever, I have a little bit of cough, what should I do? And that's a major question that we get on a regular basis. With Ministry of Health, there is actually 3 hotlines. So there is actually 397 where they can call to. Now they have what they call it عيادة طمني. You can actually book yourself into the clinic and go and there. It's a walk-in clinic. And the third one is actually by contacting the primary physician in oncology at least. But to make it short, anybody who has positive swab need to be quarantined as per the local regulation. So nobody is positive at home, that's for sure.
Okay, Dr. Hashmi, thank you. Dr. Salwa has a comment before, please.
Just my comment on Dr. Majdi's answer. Internationally, it's different regulations for when to get the donor. It has to be 4 weeks from symptomatic donation, the patient has symptoms, or 2 weeks from recovery, they can start collecting the plasma. There is certain centers collecting after 2 weeks of recovery. This means it's mainly it will be 3 to 4 weeks from the infection. And this means that the antibody will start to increase. But it's much better to do it 4 weeks after recovery. And this will be expected at the peak. But they can do from 2 weeks. Usually they are doing till 8 weeks of recovery. They are collecting plasma, and it's different from center to center. That's it. And for patients, as Dr. Hani said, they should only represent to the hospital if they have clear symptoms which affecting them, and let them need a special medical attention. Apart from that, they have to have quarantine in certain areas, away from their families, away from others, not to affect others because of the positive testing. Thank you.
Thank you. Among the questions, actually, there is a question, what are the risks of convalescent plasma COVID-19 patients? What are the risks of convalescent plasma when given to that COVID-19 patient? It has supposed to be a treatment or passive immunity, but is there adverse reaction for this? I think Dr. Magdi mentioned some adverse reaction before. Like any plasma protein.
Dr. Majdi, you want to answer, or you want
No, please answer? Go ahead, Dr. Asal.
Okay. The plasma, convalescent plasma, it's like the fresh frozen plasma, like blood components. Same side effects we expected from convalescent plasma will be expected from the components, the same exactly. It can happen any side effects due to transfusion of plasma, but it's usually safe, mild, if we just choose which convalescent plasma, which donor we can use, and how we can recruit donors for convalescent plasma, as a multiparous woman is not a good recruitment for convalescent plasma. And it's better to depend on males and on ladies who are not pregnant before, or you should do the HLA antibodies to these women that to avoid the TRALI, and we are worrying in just transfusing plasma from TRALI mostly and TACO. And this means TRALI because of this antibodies, and we can avoid it with choosing the donors and testing donors. For TACO, because we are giving a small doses, as Dr. Majdi mentioned before, maybe we are not worrying about it if the doctor the physician treating patient knows what they are giving fluids and how much they are giving. I think it is safe. And I don't know, Dr. Hani and Dr. Majdi, what they are thinking about it.
There was a recent study about 5,000 donations, transfusions of COVID plasma in the US. And it was the first hemovigilance study. I think they reported, like, if I remember well, maybe Dr. Hani also knows about it, is like from 10 to 12 adverse events with different severities. And some of them, I mean, was like death, but they could not identify if this death was due to the plasma or due to the disease itself. So, I mean, this is the beginning. We will see some of the numbers can be, I mean, alarming, but they are not true, because when you are doing a clinical trial, you record everything that you do not record in your routine work.
If I can just comment on your answers, Dr. Majdi, I go through this article. They find through this article and other articles also published that it is safe to give the plasma, convalescent plasma, and this is a minimal of a lot of patients. You stated that it's many patients, many donors they are included, and many patients, and it is not. It's very minimal side effects which is happening, and this is same like if you give blood component. The death in COVID-19 severe cases, it has a lot of things you can't decide, and you can't blame plasma by itself. For they are not sure of anything, any severe side effects due to plasma, and most of the experts saying that till now they find it is safe enough to give. Maybe Dr. Hani can give also a comment.
So just totally agree. Additional safety measure for convalescent plasma is actually viral inactivation. So to me, it's a little bit much safer than FFB because it goes through this viral inactivation process. And that's what we use here in our protocol. So as you said, it's actually male mainly or nil pares female, but HLA testing is being done for the plasma to avoid any risk for that. But as I agree with Dr. Majdi, in clinical trial, you actually mention everything. If the patient coughed, they wanted actually to put it on the list as a side effect. So you end up having a lot of side effects that has nothing to do with the plasma.
No.
In our cohort that we treated, we had a few deaths that actually all of them, not related to the convalescent plasma. All of them was actually deemed not related by the treating physician.
Okay, actually, please, there is, it's a more clinical question also about the different way of treatment and different pathway for treatment. Now, for example, there was chloroquine, there was another anticoagulant, and there's many protocols. So is there a communication between the different protocols done all over the world? And then it can be filtrated to get at the end a unified system and a unified pathway and unified protocol to treat COVID-19. Most of the disease has its pathway if have a patient coming by thrombus, by so and so and so. But is there a communication at the end to get the highest success result that can be used? This is open question for.
And I can give a quick comment on this. It's still very early in terms of the disease to say what is the best protocol to follow. And because of the surge in number and because of the pandemic situation for the globally, people would like actually to use many things at the same time and not restrict to one protocol of treatment. So as an example for the convalescent plasma, if you look at all the trials that has been done, all of them were actually very inclusive. So patients could be receiving any type of therapy, actually could be receiving also investigational drug plus the plasma. So it's inclusive rather than exclusive. So there is no exclusion criteria for treatments such as antiviral or antimicrobial or anti-inflammatory. So the disease itself is actually is critical enough to allow for all those to come. I'm hoping that with more knowledge, more research that's coming out and result of those trials, we'll be able to actually start tease apart which actually is actually better to start with and what's the next options, or third options. I'm hoping that we're not too far from that, but it's very difficult now.
But is there a contact between the result with WHO for the trial, the different programs, and then what is the most successful one? Is it going on or not? No, Dr. Asal say no.
Okay. No, because till now they are not sure which medication will be better for treating COVID-19. And it's all under research and trials, and they are trying their best. And what I'm thinking, like hydroxychloroquine, if you ask, maybe in Egypt, they find that very good results coming with it. And maybe in another country, they said, no, it's nothing. The results may be bad, going towards bad results. We are not sure. The population itself, the patient's population, maybe the medication itself, how much they are giving, the protocols, if this medication really will affect patients positively or negatively. Nothing till now clear, either from WHO, from anybody else, except that some of the medication which already put it in international, protocols and in our national protocols, they are good, and it can be of some good effects on patients if we are using it. We still not know exactly which medication will be the best and which protocol to follow. Because this we are trying to bend on whatever immunity and improving immunity of the patient, giving plasma, giving immunoglobulin, all these things will help in treating patients with COVID-19.
So our speakers, do you have questions to each other or something need to clarify or to focus on or comment?
I think there is a confusion for, I just looked to a few questions. I think there is a lot of questions from the audience, and there was confusion about antibody. I think what is the benefit of antibody when it will come the antibody, why we test antibody. They are thinking that if we do PCR, PCR detecting antibody and not the virus. So I think we need to just clarify that PCR, it is a diagnostic test and it is just getting the virus. We know that the virus is there, it's positive, they have the positivity. I mentioned in my graph that maybe the positivity PCR become negative in certain time during the infection. Antibodies testing will help just to diagnose or help in diagnosis, but it's not for diagnosis at acute state. Can help if the patient becoming PCR negative, you may find IgG and IgM together, and this will say that this patient had COVID-19, even if he is asymptomatic or have mild symptoms. And I just stated also in my presentation, doing antibody testing can help and just do screening, know the contact of COVID-19 patients, helping in knowing the immunity if it's built up, and we have IgG when we have the IgG in higher titer. This will all help in doing things, also choosing convalescent plasma, doing epidemiology study. Serology testing is helping, but it's not the diagnostic testing. And PCR is the diagnostic testing. And this answer of one of the questions, I think, but from the audience. I just want to ask Dr. Hani if they have a positive results, preliminary results, positive, that it can say that we go ahead and give our patients convalescent plasma under research, also because we have to do it under research, and we're just starting because there is other groups in Saudi Arabia, they're starting their research on. I know about 2 other groups, they are starting now, but they didn't yet start giving patients plasma. Do you think that it's good to start and try? Do you have a positive, good results as a start? I know that you can judge now and you can give your result now, but as an advice or suggestion, what's going on?
And my sincere advice, if you have a research protocol that's up and running with the group, I would rather actually do it within the research protocol. And if there is groups that's actually collecting data prospectively, would be the best. Internationally, now we know that it's safe. Many reports are coming to say it's safe to give convalescent plasma, providing that you do the proper collecting methodology. We are actually within the same context. We are actually in line with other people who reported their data. Very preliminary, we're seeing a good result, and we've seen an improvement in some of the parameters. It's very difficult to say this improvement is true without looking at the full result and actually comparing this with the matched group. So until we actually do the comparison with the matched group, this is just an observation. Like in safety is pretty much now is not debatable. If the group is actually ready to start the project, then it's nice to collect it on a clinical trial.
Yes. Thank you, Dr. Hani. And Dr. Majdi, do you have any results starting in Egypt because we heard and we have news that from Egypt it was good and giving a positive results. Is it right? Your microphone, Dr. Majdi, is closed. Off microphone.
Yes, sorry. So, I mean, I'm not into the COVID plasma trial, but I mean, according to the Minister of Health, they said that they have infused 19 patients and that they saw some good results. That's all what I know, but on what basis? I do not know. For us, we have not started infusion yet with the hyperimmunoglobulins.
Okay, thank you.
Please, I have a question also from our audience. For pregnant COVID-19 patient, she is a pregnant and she is now has COVID-19. Can we give this plasma? Is it safe for her?
طيب يعني I'm just starting because we had a patient pregnant patient who received plasma, so it's not part of the exclusion criteria. I know it's actually very difficult situation to make the judgment of, but if the protocol is being explained to the patients and whoever is actually the next of kin, and they agreed to receive the plasma, I don't see any reason why not. And we actually do have a patient, a pregnant lady who received plasma.
Yes.
I think personally, I think that I agree with Dr. Hani, but this is not usually in most of the trials now. They are excluding pregnant ladies. They're afraid from maybe reinfection with COVID-19 through the plasma. But I think if we are doing pathogen inactivation to the plasma and giving to the pregnant lady, as we are giving her any blood component if she needs during pregnancy. And I think it is feasible, but we didn't do it.
So this was exact discussion because when they actually took it to the ethic board, they said she's already positive. If she's going to give the virus to her baby, the baby already has it. You're going to do inactivation of the product, so the product supposedly safe. If she needs plasma tomorrow, you give her plasma tomorrow anyway. So maybe this is just part of the routine. And it was not an exclusion criteria on the trial. And I agree with Dr. Aselwa, most of the clinical trial exclude minority and pregnant ladies.
Yes, so less than 18. No, there is studies for pediatric patients. They started in US, and they are starting giving pediatrics. But because pediatrics or children, they have milder disease, they may not giving but they do a trial now for pediatric age group. For pregnant lady, I think it is safe, apart from side effect of plasma in general. But I'm not sure if this going internationally or not, or there is no discussion about pregnant ladies.
Just before closing, I have a question inside. What is the magic happening in China? Complete cure and complete return to life and everything is okay now, nothing at all. Why? Somebody knows the secret?
I think they're actually getting a second peak now. So Beijing is already close of their areas because of new cases has been reported. I think we're going to live with this virus for some time. We just need to have more precaution in how we deal with things. Yes, they announced they're actually 0, but now they started recording at least 40 in the last, actually more than 40 in the last 24 hours. Same thing with our colleagues in Jordan. So they announced the last, and just today they actually had 24 cases positive. So it's a new reality that we're all going to live with for at least another year or so.
And another reason, maybe because China, they do the lockdown, complete lockdown early in the disease. This may help them and just contain the virus for a while. But the peak can happen at any country, at any place, anytime, and we can't be assuring that anyone who have 0 cases will not have any more cases. They still not know about this news international.
Anyhow, I thank too much all our distinguished speakers and their value and their importance, which they give to us. And it was very valuable, very fruitful. And of course, we are waiting for results. It's a different disease, very vague disease, still question mark many about it, even about its pathogenesis. Still, many times in the pathogenesis, we read more new papers, some in coagulation, some can cause GIC problem, and still we don't know. Another result of using the convalescent plasma, which is our topic, we will wait and maybe we will need another webinar, inshallah, maybe after some time to get the results of Dr. Hani, Dr. Magdi, and Dr. Aselwa. Of course, we will need to know more about the results that can be more valuable for all the disease and the risk group people, either as a treatment or either as a passive immunity for the exposed person, especially the healthcare provider, doctors and nurses who are exposed always for that, and many of them are victims. Thank you very much.